Good afternoon and welcome to the 2025 European Healthcare Climate Summit. My name is Andreas Ekvall and I'm joining you live from Paris. I'm the Senior Climate Officer at Healthcare Without Harm Europe, and it's my privilege to welcome you to the 7th edition of this annual event. On this 9th of October 2025, we find ourselves at a pivotal moment. The theme for this year's summit is climate resilience at a halfway point, mitigation and adaptation in a warmer Europe. Why the halfway point? Because we are now halfway through a decisive decade for climate action, yet current policies and efforts are falling short of the emission reductions needed to limit warming within the 1.5 degrees temperature threshold. Meanwhile, Europe is already experiencing worsening health impacts from heatwaves, floods, and wildfires. This crisis presents the healthcare sector with a unique and urgent dual mandate. As a significant contributor to emissions and a frontline responder exposed to climate hazards, the sector must act on two fronts: mitigation and adaptation. These are not separate paths, but two sides of the same coin: climate resilience. This summit is designed to bridge the gap between these two essential areas. Today, we will explore both system-wide strategies and practical on-the-ground solutions, driving resilience across Europe and beyond. You will hear from leaders and have the opportunity to connect with peers in networking roundtables, sharing experiences and addressing challenges together. Our collective mission is to reimagine and transform healthcare for a climate-resilient future. By the end of today, we hope you will leave with practical tools, new insights, and a stronger sense of direction for advancing climate resilience. Before I introduce our keynote speaker, I'd like to briefly highlight some of the platform's features. On the right side of your screen is the live chat tab. You can share your thoughts, comments, and questions with all attendees. Let's test it now. Please type your city or country to let us know where you're joining from today. The same chat box is where you can post questions for our speakers. If any questions are not answered live, speakers can respond afterwards on the platform. You can also connect directly with fellow attendees and speakers via the People tab at the top of your homepage. Here, you can send messages or bookmark contacts for later networking. Later today, between the plenary sessions, we will host networking roundtables. These will run for 20 minutes and you can choose a table that interests you the most. You can access them by navigating to the networking tab at the top of the homepage. The tables will be open for selection when the networking session starts. Now, it's my pleasure to introduce our keynote speaker, Dr. Ernst Kuipers. Dr. Kuipers is Vice President at Nanyang Technological University in Singapore. He served as Minister of Health, Welfare and Sports of the Netherlands and was previously President and CEO of Erasmus University Medical Center. He's a trained internist and gastroenterologist with extensive leadership experience, which has been recognized with numerous awards and honors. Welcome, Dr. Kuipers.
Thank you very much. Thank you very much, Andreas. I'm fine, and I'm actually speaking to you from Copenhagen, where there is an EU health summit where I can tell you climate and climate change and the need for change, mitigation and adaptation from healthcare is also very much on the agenda. And so it's a real pleasure to talk about these topics as keys to healthcare climate resilience. If we can move to a next slide, it will show you a wonderful picture, a joyful picture, which appeared in 2019 on the front page of one of the Dutch major newspapers. You see some kids having fun while playing in the North Sea. The only dystopic part of the picture was, if you can see in the lower left, is that the picture was published at the end of February 2019. And for those of you who are familiar with the North Sea, I can tell you that February is not regularly a month where you would swim for pleasure, and certainly not for kids. You would only start doing so by somewhere mid-June. So this was out of order and the reason for being published. And it happened, if I can see the next panel, it actually happened at a time when we in Europe already had extreme temperatures and temperature records for 5 years in a row. 2019 would not break the record till then, but came very close. But since then, 2023, 2024, we have already again broken the record. And this is the global temperature. But you should be aware that in Europe, the temperature change, apart from the Arctic, we are the continent with the fastest rising temperatures, and we are already at plus 2.4 degrees Celsius. Next slide. And that change was really the reason for developing 10 years ago in 2015, the Paris Accord. It was not a one-stop solution, but it was broadly a call to action and a call to finding many, many different solutions. And you may or may not remember, but at the time, President Obama called it the best chance we have to save the one planet we have. The Secretary Generals of the United Nations, at that time Ban Ki-moon and later Guterres, also put it at the heart of the policy of the United Nations. But now, 10 years later, we are in a totally different situation, as you're well aware. President Trump has withdrawn the United States from the WHO. The whole script is drill, baby, drill. We've seen a COP meeting last year where the president of Azerbaijan said that oil and gas were basically gifts of God. And if we move to a next panel, also in Europe, we've seen that there are very significant changes, and the EU Commissioner Wopke Hoekstra is really having difficulty to get all of the EU countries together in one bold agenda for for sustainability within Europe. Next slide. And this all happens while we, and I think all of you in the audience, are very much aware that climate and climate change affects our health in many, many interrelated manners. If you just look at the lower panels on the horizontal lower left, you'll see the impact that it will have in terms of exposure to infectious diseases, pulmonary disease, cardiovascular disease, mental disorders, and many others. And apart from that, to the right in the green vertical bar, also the many other parts where it's like poverty, undernutrition, loss of habitat, migration, and all of this, as I mentioned, interrelated. Next slide. This happens while at the same time, in the way we provide healthcare at the moment, we actually contribute to the climate change because our footprint as healthcare sector is very, very significant. You are well aware of many pictures. I usually like to take one which is a little bit out of the box, but just showing and making us aware that throughout Europe, the largest healthcare providers, like very large hospitals, on a daily basis produce an amount of wastewater which is similar to 1 to 2 Olympic swimming pools. This is the wastewater from just one healthcare provider. Next slide. And that also altogether means that if you see the measures or the lack of measures and the change in the temperature and the impact that we have themselves and the awareness that we have to take care of many more patients, that many healthcare workers actually become very disillusioned and very tired. Next slide. And yet, at this particular stage, I would like to remind you of one incident, I would call it, of Apollo 13. You know the story that was going to put people on the moon. On the way to the moon, there was an explosion of an oxygen tank damaging the outer structure of the capsule, as you see in the upper right panel. And then the lead, the director of the Space Control Center supposedly said, "This is going to be our best moment." This may sound as a very cynical remark, but what he actually meant, under these circumstances, under this terrible pressure, in a situation where there's apparently no outcome, no way out, we are going to solve this. And I think this is the approach that we also have to take in healthcare, as healthcare providers, as professionals, as patient organizations, and say, this is going to be our best moment. We can tackle this. Next slide. And the way in doing so, first of all, came from the WHO. I worked a lot when I was a Minister of Health in drafting and helping to draft this resolution, which was accepted at the World Health Assembly last year in May. And basically is the call, like with the Apollo 13, Houston, we have a problem. This is the Houston, we have a problem call, stating very clearly, globally accepted, that the pace of climate change and environmental degradation emerges as a major threat to human health. And if you see on the lower panel, it had created a particularly challenging environment for countries to protect and advance their health and well-being. Next slide. Once we have that very important call, the next one is to bring forward that health is really the argument for climate action. It should be central in any discussion we have, whether we focus on our planet, whether we focus on the place and the environment, or on the people. In any discussion, health, our human health, should come at the central argument. And this is a statement clearly also from the World Health Organization. Next slide. Apart from that, there is a further call, and to the right you see a report from the WHO Council for the Economics and Health for All, that when we do so, that we should put health in all our policies. Every individual policy in any individual country, as well as at the EU level, should put health central, value health for all, finance it, innovate for health for all, and also strengthen public sector capacity. Next slide. And that also means that when we focus, and Andreas already mentioned it, when we focus on the mitigation, we have a lot of work to do as a healthcare sector. This is just one example of the largest healthcare provider in the Netherlands, targeting and fully specifying for any patient pathway they do in any research project, the full carbon footprint. And with that, once they had that, they could target it on the next slide and see that actually with doing so and very deliberate measures throughout the whole of their healthcare activities, that they were able to reduce their carbon footprint both per FTE, with from 2019 to 24 already a reduction of 20%. And because they, at the same time, increased their patient numbers, if you look at it from a patient perspective and per patient, in the total, it was a 12%. Next slide. So that's many measures for mitigation. And the other one, as Andreas mentioned, is the adaptation. I'll deliberately put up a slide which reminds us of the COVID situation, but we have to make our systems very resilient, as we did at that time, by connecting, by preparing, by monitoring, by surveying, and so on and so on. Next slide. So that is one of the major topic of the next Pan-European Commission on Climate and Health, of which I'm currently a member. You see the pathway for the Commission, and we will deliver a bold and very pragmatic report by May next year to recommend to EU countries and also globally what to do in this respect. So with the final slide, I hope that this is a start. Next slide. This is a start to really say the future can be bright and can be beautiful, but then we have to take action now. Thank you very much, Andreas.
Thank you so much, Dr. Coopers. Your insights set the stage perfectly. The warming temperature and environmental degradation are truly a challenge to health. Health is a clear argument for climate action. Now that we are energized, let's move into our first plenary of the day. Building resilience top-down, system-level efforts for climate mitigation and adaptation. In this session, we have invited a series of speakers to explore system-level strategies for building low-carbon, resilient healthcare. featuring examples of initiatives and policies that drive large-scale change. Before we get started, you can submit your questions in the chat throughout this session. We'll have a Q&A at the end to address them. Let's begin. Our first speaker is Erland T. Asheim, Specialist Director for Sustainable Health and Care Services at the Norwegian Directorate of Health. Erland has been leading efforts to embed sustainability into the healthcare sector at a national level. Welcome to the stage, Erland. Hi, Erland. How are you today?
Thank you. Well, I feel great. Of course, it's fantastic to have this webinar, and I'm very much looking forward to the discussions we will have.
It's great to have you with us. We can also see your presentation now. The floor is yours.
Thank you. Well, thank you so much for the invitation and for organizing this important webinar. So I'm going to talk about the Norwegian context and some efforts that authorities and health authorities and services are doing in our country. So the way I'm going to do this is first I'm going to give a very brief introduction to the Norwegian context. The bulk of my presentation will be about the roadmap itself, and then I will finish with a single slide on experiences with the uptake of the roadmap and some thoughts on future potential since the roadmap was launched earlier this year. So in terms of the Norway context, what's important to communicate on this slide is what is demarked within the yellow boxes here. And the main message really is that in terms of measuring greenhouse gas emissions and driving change, we have to tackle this a bit differently in Norway in terms of the specialist healthcare sector and the primary healthcare sector. So as you can see here, hospitals or specialist health services, they are formed by 4 regions, and these are more or less directly under the influence of the Ministry of Health, whereas primary healthcare is delivered by some 350 municipalities who are also responsible for other services such as schools, waste management, etc. So it's a different ballgame in terms of how change is implemented through different policies. And myself, I sit in the Directorate of Health, which is an executive agency under the Ministry of Health. So like many other countries in recent years, Norway is supportive of various climate and health initiatives. Just listed some of the initiatives that Norway are supportive of here. So the landmark change perhaps was the COP26 health program, which is the basis for the development of the roadmap, which I will speak to. And it's good to hear that now more than 100 countries have signed up for the COP26 health program. And personally, I'm also looking forward to the launch of the BLM Health Action Plan at COP30. I'm sure many of you will be interested in following the agenda at COP30 in Brazil as well. So in terms of the COP26 commitments, we have delivered several products. So first one was a national review of health sector emissions, which was published some 2 years ago. We also published like a brief summary of this review, which is available in English for those who might be interested. So the conclusion there was that the Norway health sector emissions are large, and there's a lot of potential for reductions in this large sector. So a sort of an estimate of the size of the emissions is around 5 megatons of CO2 equivalents, including scopes 1, 2, and 3. Just to highlight that we have a much better understanding of emissions in the specialist healthcare services, where they have a national reporting system for CO2 accounting, including also scope 3. Whereas for primary health and care, we have based our estimate on some 20-30 municipalities and assume that they are representative of national emissions from municipalities. And the remaining of the health economy, which constitutes some 30% of the Norway health economy, that's private healthcare services, pharmacies, academia and research, health, other parts of the health industry. It remains some 30%, and we don't have a good summary of all of the emissions there. But in terms of specialist healthcare services, we have a very good overview now, and this slide illustrates data which is available online. Unfortunately, not in English, but I've tried to translate some of these words here. As many of you will know, emissions from scope 3, or primarily supply chains, constitute the vast majority of emissions in the health and care sector. Here we see national emissions from specialist healthcare. We can note, for example, that medications constitute some 11% of emissions from specialist healthcare services in Norway, whereas information technology is already around 7 to 8% of emissions. So it's interesting to have an overview of the size of these different emissions areas if we're going to have targeted interventions, of course. And as one policymaker from Spain put it a year ago, we really must have emissions data to be able to communicate and tackle these challenges. So I'm going to talk then about the roadmap for sustainable, low emission and climate adapted health and care services, where we also have an English version available online for those who might be interested. So this roadmap was developed by a small team in the Norwegian Directorate of Health as a task that we were given by the Ministry of Health. We had conversations, of course, with specialist healthcare services and the municipalities who were sort of, from our understanding, have taken initiative and done a lot in this area, including measuring emissions from their healthcare sectors. The published version of the roadmap itself has an introductory statement by the health minister, where he describes that he hopes this roadmap will inspire all of us to implement sort of the climate perspective into and mainstream it into our daily work. So in terms of the content of the roadmap, when it comes to action areas to reduce healthcare emissions, these are the 6 areas that we pointed towards. We also have chapters dealing with adaptation, but most of the roadmap deals with interventions to reduce healthcare emissions. So we have here 6 intervention areas, which include healthcare and prevention. That's the biggest one. But we also deal with sort of the whole system, including also procurements of goods and services, a big area of emissions, transport and travel, circular economy and waste, buildings and energy, and digitalization. Digitalization was inspired, I think it was France. We saw it the first time that they had a roadmap which included digitalization as a separate area. So one thing is telemedicine and these issues, but there is also important to think about including sustainability in the way we do digitalization in itself, because it could become a major driver of energy use if there is a revolution in how we use artificial intelligence. But also there is a lot of work efforts and resources being put into digitalization of healthcare. So if we can join forces and ensure that we think green digitalization, this will help serve both agendas. And the roadmap is filled with a lot of actions. We didn't have a joint document that sort of was a shared or pooled resource in this area before, so we felt it was important to gather as much as we could in terms of practical examples of what healthcare services can do. So examples of action areas, I'm just going to list examples of the areas where we have actions under the healthcare and prevention umbrella. So here, of course, we talk about medications, we talk about overuse of services, we talk about how we serve diets in various contexts, we talk about patient safety and action plans, as well as prevention and health promotion. So So what you will see here is that this is not just climate change agenda in itself, but it goes beyond that. And it's about how we can take a wholesome approach to how we develop services, where some of the things we do will save both resources, lead to better patient outcomes, and be beneficial for the environment as well. So some of the areas where we have had major progress is in the use of desflurane, a major CO2 emitter from anesthetic procedures, where hospitals have reduced usage by 95% in recent years. And a different action that has been taken by the Directorate of Health was to send information to all municipalities about vulnerable populations they have and what actions they can take to mitigate consequences of climate change in an annual public health profile that we send to municipalities. So we also have give tools to succeed in terms of implementing the roadmap, where we point to the importance of having greenhouse gas accounts, the importance of leadership structures, and to work on how to increase knowledge and awareness. But I'm not going into the details around this in our presentation now. I'm going to just quickly point out that the whole aim of this roadmap is really to give a framework that gives the opportunity for all of those who work in the health and care sector to engage with the climate change mitigation and adaptation agenda. And while some of these actions are expected to be done by most organizations, others are more meant as a resource for local innovation and service development. So I'm just going to leave this last slide here. It gives some early evidence of uptake of the roadmap, which is really good. And it also points towards some further areas of potential. So chiefly, there is emerging evidence of uptake in how we do national policy development and in the work that specialist healthcare services do. In particular, Oslo University Hospital, one of Europe's biggest hospital organizations, have now developed a new sustainability strategy which heavily features climate change. Whereas we have more work to do in terms of promoting the roadmap in general, and in particular in how we engage with municipalities and serve as a resource in their work. So I think I'm going to leave it at that to ensure I don't run too much over time. Thank you so much.
Thank you, Erland, for setting the stage with how national strategies can drive systemic change. Norway is truly taking an innovative approach to measuring and showcasing emissions bottom up. I would like to start off with asking you a few questions. I'm currently experiencing some technical issues here with my camera. Please bear with me. We are fixing this. But in the meantime, Erland, could you, I'm really curious to hear more about the roadmap and what have been the major opportunities and challenges in developing baselines and roadmaps. Do you have one or several key recommendations for other both health systems and ministries of health?
So I think we were very fortunate in that the specialist healthcare services already were doing work in this area. So they've started with the hospital with a project called Green Hospitals in 2008, and they've been working sort of under the corporate social responsibility type frameworks that have been national policies. So they had, before COP26 came up, they had agreed amongst themselves, the four regional healthcare trusts had agreed on some pretty ambitious greenhouse gas emission reduction targets. So with these goals already established, it was an opportune time, I would think, for Norway to join the COP26 health program. So in terms of municipalities, they work more across. So they already have reporting systems where transport and buildings and energy, they already have their own reporting mechanisms, so to speak. So that is more of a challenge to see how can we, without adding to the reporting burden, somehow be able to track emissions in the the health and care sector. So I think maybe it may be that we need to take an approach where we um, although we want to focus on emissions, we also need to be able to maybe track what activities are important to start, and have some other types of process measures as well as simply relying on greenhouse gas emissions data. So I guess the advice here is to try and utilize and capitalize on the strengths that are available in your particular context in order to get some wins in at the outset, and then have something to build on.
Thank you for that. That was really insightful. Following up on that, I think you mentioned alternative indicators as well to carbon dioxide emissions or carbon dioxide equivalents. Have you been starting to look into additional indicators covering other areas of environmental impact?
So what I had in mind was to start looking at some hotspots for emissions. So one example relevant to the health and care sector there could be asthma inhalers, and try and optimize the usage of where we prescribe which type of inhaler to which patient. So because we managed to change some of the reduction to change usage of desflurane in hospitals, and this has mainly been driven by clinicians themselves through awareness raising, I think. So I know there are good examples from the UK where they have had a lot of awareness raising in this area, including conversations with patient users, organizations, for example. So I think prescriptions data, as we have more information on which sort of pharmaceuticals have a more favorable climate or CO2 profile. So if we can change products while maintaining the same level of quality of care, then that would be very useful information to have. So I think new indicators will develop as we develop more knowledge about different products and their environmental impact.
I agree with you there. I think that's a key challenge moving forward, finding broader indicators, especially when it comes to circularity, but also when it comes to other products such as chemicals and pharmaceuticals, and how we can operationalize that in the ministries of health. You mentioned awareness raising as essential. How are you working with awareness raising, and how are you getting hospitals on board on calculating their carbon footprint?
Yeah, thank you for that. So I think that here is a huge potential to gain momentum without necessarily introducing new regulations or putting massive amounts of money into different interventions. So it's really something we should exploit to the fullest. So there's several key target groups here. So one is healthcare personnel who are actually practicing, because they will be important sort of on the ground stimulators of service change. But also health leaders. I think it's really important to get on board, and that they have the latest information on what is actually government policy, and how can they, over time, as they have data on emissions, look at emissions data as well as other types of data when they discuss how to develop services further. So we want to move from a stage where we're looking at patient outcomes and money alone, and thinking more sort of broad, holistic around how we consider healthcare service development, in addition to other sustainability aspects, of course. So we often get these questions. So one key challenge, in addition to climate change, is scarcity of healthcare workers. And sometimes when people discuss sustainability, they mean different aspects of sustainability. But I think one of the key challenges is so sustainability, as I understanding, is not a concept that you split into silos, but is more having the whole holistic approach. And to raise that understanding, we sort of need to bang the drum for climate change a lot, so that it becomes mainstream and not an activity sort of that takes place on the side.
Oh, I agree. And I think that's a challenge. And I think it also comes down to how people working with sustainability operationalizes different indicators. Do you have any suggestions on how we can make sustainability indicators more relevant for clinicians, especially when we're talking about these indicators on a very high level? So making them easy to access and also understandable to a wide range of audiences. I think for me, that's a challenge. But how are you working with these questions?
Yeah, these are all very good questions. So in terms of, I didn't respond fully to the previous question on how do we communicate or raise the profile of these agendas. I think we try to make it into strategic arenas for decision making, and to make sure they are aware of the roadmap and the policies that it sort of includes. So, for example, we were in a national priority panel a couple of weeks ago, which discusses introduction of information technology changes, and they are now supporting the roadmap's ambitions and its actions. So that will help us to ensure that decision makers are aware. But I think we both need top-down and bottom-up actions in this area. And to get bottom-up actions, we need to have healthcare personnel and others see the benefit of their work. So we had a wonderful example at a local hospital in southwest Norway, where a nurse decided to look into, can we reduce the amount of single-use equipment with a particular eye procedure without compromising on patient safety and the working environment. And they discovered, when they looked into it, that they could not only save waste but also save money and improve the working environment at the same time. So I think if we can sort of support and strengthen and magnify such good examples, and think, how can we scale those initiatives up so that they can, that would by giving awards maybe, or other things, so that they could see, okay, you've done this now at one outpatient clinic. What if we roll this out, regionally or nationally? What would that actually mean in terms of emissions saved and the resources saved? And potentially, if this adds up, then actually you could fund posts. Just by doing this, you might save money and improve the environment as well. But I think to have those examples to make business cases would also be something that gives leaders of those healthcare workers who try to drive initiatives, it would give them the confidence that they can let them set aside some time to do it.
I think you're getting to the heart of a really complicated question, especially for health systems that have less mandate as well. Trying to get clinical personnel and sustainability managers as well to engage and do this work. And this, I think it's essential moving forward to create these kind of incentives that you're mentioning. Thank you for that. It's been really insightful, and thank you for answering all of my questions. We're now going to be joined by our next speaker, and our final speaker in this session is Dr. Courtney Howard. Dr. Howard is an emergency physician in Yellowknife Steam Territory in Canada's subarctic, a clinical associate professor at the University of Calgary, and vice chair of the Global Climate and Health Alliance. Together, Courtney brings an unique perspective from the clinical front lines and on global climate advocacy. Welcome, Dr. Howard.
Hi, thank you so much for having me. This is really just wonderful to join you. And in fact, that's exactly what I'm going to be talking about. How do we take these commitments that we've made at the global level and bring them down into our country level? So the slides will go quite quickly. To situate this global audience, Canada is warming at double the global rate. So if these numbers look alarming, it's because where we are, we're just getting warmer faster. And in fact, where I live in the subarctic, we're warming at triple the global rate. And so doctors tend to be very surprised when I show them this graph and essentially show them that no matter what we do now, we are going to keep getting warmer for at least a couple of decades. And then, of course, if we get onto a very low emissions pathway, we have the opportunity to flatten the curve. But the media is still not very clear on this in Canada. I get a lot of questions during wildfire season, like, Dr. Howard, is this a new normal? And I say, you have not looked at the graph because it does not level out in the year 2025. So what I find is when I start with this with my colleagues who are just new to this, I can see the wheels starting to turn in their heads. Next slide. And when we start to talk about the children who are born today, and I did this math a couple of years ago, they start to really personalize this for the child whose teeth they're brushing, et cetera, and they can see that the impacts are really tangible. Next slide. And so we know we have to adapt, but we have amazing opportunities when mitigation is concerned if we all work together. So a tipping point is a critical threshold beyond which a system reorganizes, often abruptly or irreversibly. And so we know that there are tipping points in the climate system we want to avoid. We also know that clean technology is already almost at a tipping point, and that if we move together as a sector, it's possible that we can be the change that drives those markets towards irreversible tipping, towards clean energy. Next slide. And so some of the reasons we can do that is that we're big. So unfortunately, the impacts of fossil fuel related air pollution are big. Different studies come up with different numbers, but we know that at least from one study, Bora et al., almost 18% of global premature deaths were attributable to fossil fuel related air pollution. That's like close to 1 in 5. And meanwhile, we're responsible for about 5% of greenhouse gas emissions on a global scale, and we allocate 10% of global world product. So if you think of the saying money talks, we have a lot of money to allocate in terms of strategic procurement to start to shift markets. Next slide. Next slide. And so when we were organizing the COP26 health program, I was part of the WHO civil society working group on behalf of the Global Climate and Health Alliance. And of course, healthcare without harm was extremely fundamental to this. I remember Josh Carliner, he was trying to get us all to get our country signed up. I'd spoken with Canada before going. We got in the nurses associations, medical associations to support this, but Canada was really on the fence. And then what happened was when the US signed on publicly at the halfway point, all of a sudden countries started to pay attention, and we developed this healthy competition spiral so that by the time we walked out of there, 52 countries had signed up. And I just want you to take a look at that set of tactics, because we eventually did the exact same thing here in Canada. Countries, I was surprised to learn, are not that different than kids on the playground with a new set of shoes. We're such social animals that the more we can create a really clear yes or no question, a time limit, and a sense of healthy competition, I think the better we're going to do in terms of accelerating ambition. Next slide. And, a couple of things that are challenging for us here in Canada. So we got that done. I came back to Canada. I said, okay, doctors, now we are internationally committed to decarbonizing healthcare. What are we going to do? And they looked at me because really Europe is very much farther ahead than we are here in Canada. And we have 14 health systems. So we know that the NHS has been aided by the fact that they're a single employer. And so they can produce a beautiful evidence-based graph like this. And with a lot of work and cunning and evidence-based maneuvering, make this something that goes all the way through the country. Every hospital there has a green plan now. They've written this into the Health and Social Care Act. They're legally bound to it. So we have a very big country. We have 14 healthcare systems. And so I've spent a lot of time thinking, okay, well, how can I make that happen here? Next slide. And of course, everybody comes to this as a single individual. Just keep advancing the slides. And often we're tempted to just be worried and try to do it all ourselves. And that does work. Yeah, keep advancing it. We choose a strategic target, tell stories that speak to people's hearts, either win or lose that thing. And then if you lose, okay, well, almost every single time you've gained resources and you can try again. If you win it, what happens is it builds hope, and that attracts further resources. Next slide. And so we want to be creating and really being clear about where we're going in terms of an aspirational vision. Next slide, just go very quickly through these slides. So we know when we decrease air pollution, we save lives. The physician voice can be very important in terms of helping to accelerate a transition away from coal. We go on TV with our scrubs on, say we have to close the coal-fired power plants to keep the kids out of the emergency department with asthma. Just keep going. We know that if people get onto their bikes, it decreases mortality. Just advance. Clubs like the Powering Past Coal Lines can help to accelerate ambition. Making a map of your city and showing where everybody's getting hit by cars on their bikes and proposing an alternative map can be very helpful. Nature prescribing, so my good friend Melissa Lim is taking off. Evidence-based policymaking. Jane Philpott was our health minister. Doctor who ran for office became health minister. I really encourage people to consider political service as humanitarian service. It's a different kind of humanitarian mission and absolutely essential to decarbonizing, as well as decolonizing global health and decolonizing planetary health. We got to clean up our own place in order to have a good impact on the globe. And that's what Dr. Philpott did. She ran an evidence-based food guide process nationally, where she banned closed-door meetings actually with the food and beverage industry. And it came out right before the Lancet played. And this is Brent Loken of EAT and Marla Reynolds, the environment and climate change ministers first in command, comparing the two sample plates at COP right before they both launched. Next slide. And they look almost exactly the same. And that's because we ran under Jane an evidence-based process free from undue industry influence at the same time as an evidence-based process. So what if we did that kind of policymaking with fossil fuels? I just think this is so inspiring. Next slide. And so this is where we're ending up. Next slide. So in Canada, and actually my co-author just got here. Do you want to, Raisa, do you want to come wave? So this is Raisa. We ran a national consultation to try to figure out how Canada could work better together. Next slide. And that involved interviews from across the country in order to action the Academic Health Institution's Declaration on Planetary Health that was done after COP26. So essentially, the Association of Faculties of Medicine of Canada took the lead, real champion, clear yes or no question in terms of commitments, deadline, International Conference on Academic Medicine. Everybody signed on because they didn't want to be the one who wasn't there. And we went from no doctors really committed to all of the faculties of medicine of Canada committed. And so then we put a roadmap together. Next slide. Next slide. And this actually was interesting internationally because a lot of medical schools around the world haven't had that happen yet. So people are welcome to sign on to that declaration. It's open for international signatories. And also just the tactics have been really, really important. Next slide. And so we spent a long winter putting the implementation roadmap together with cross-Canada landscape analysis, gap analysis, and then a series of proposals. Next slide. And so I'll get you to just keep going through it. The biggest gap was that senior leaders don't know what they don't know. And then with our desired end state in mind, next slide, and the way everything is structured in Canada, along the left-hand side, we have municipal, provincial, and national. The different ministries responsible are the black boxes at the top. We realized we actually don't have the structures we need in order to create this. So we just had a big meeting in Toronto. We had the presidents of all the medical colleges, as well as the medical associations, nurses, pharmacists in there. And we got them to work their brains on this to say, okay, well, what should come first? What should come next? What's the sequence? And at the end of the day, we all agreed that starting a National Resource Center for Planetary Health was the essential catalytic step to help us perceive bright spots, scale them across the country, create the best sort of jerry-rigged NHS type of cohesive plan that we could here in our federated system and move forward. And it really, really was, I think, the start of a new era of planetary health in Canada. So that is my global to local presentation to you. And what I think is super interesting is how energy at one level, if you carry the story between levels, it really does change what happens at other levels. So I thank everybody on the call, on the conference, who's helped to generate ambition wherever you are, because your stories are the ones I bring back to Canada and tell here to get our doctors going. So many thanks for all of this wonderful community as we work towards a healthy future together. And I wish you just the best adventures in change making this year and into the future. And if you just keep going, so you start lonely, just go quickly, you see it all becomes a big complex adaptive system, and that's how we can tip the scales.
Thank you, Dr. Howard, for sharing those important insights and for connecting clinical realities with broader policy and advocacy. You truly bring a unique perspective on how climate change relates to the realities of frontline emergency personnel and public health, but also how healthcare professionals can engage on the national and international level. I think the first time I met you was during COP29, and I asked you about what you just presented precisely, because I was so impressed with the work that you were doing. And I was flabbergasted, and I was, we have to bring this to the European context as well. We have to do something similar. So thank you for this presentation. I would like to ask you a few questions. And picking up with how you ended your presentation, what are your key recommendations for healthcare professionals who want to influence healthcare climate policy?
Find your people. During the landscape assessment, we found a lot of lonely, sad people. Don't be a sad, lonely person. You can't solve this with your one set of hands. Although your one set of hands is key, because nothing starts without you deciding to do something. So whether you come and talk to us at the Global Climate and Health Alliance, whether you speak with your friends at Healthcare Without Harm and our friends with Healthcare Without Harm, find people to help loop you in, because a lot of your path has been trodden by someone somewhere else. We've got the policy briefs. We've got the set of tactics. We know what's likely to be tough. We know who to bring in as a speaker to convince your chair. So really plug in. And it's really interesting because everybody wants something very tangible. So I find everybody wants to switch their inhalers or phase out desflurane. But if everybody's doing that work only at the micro level or individual level, what happens is it often can build kind of to the meso level or hospital level, but you still don't have access to a big budget or kind of a structure to help you. And so people, it's really, really hard to spread without a macro sort of subnational, national level of help to make this work more efficient. And what we find, like we ran a campaign earlier this year where all we actually did was go around Canada and start to keep track of everybody who is phasing out desflurane. And it turned out that in my own territory, there's only 25 doctors in my territory. I had bugged the anesthetists to phase out desflurane a couple of years ago. Then I went to Oxford and they never followed up with me. So I was like, Steve, let's phase out desflurane. And he's like, didn't we tell you? We stopped using it 9 months ago. We bought new machines. It's all gone. I'm like, you mean we phased out desflurane in our entire territory? The guy's my neighbor. He lives 2 doors down from me. So he didn't even tell me. So our headline ended up having to be NWT phases out 1 year anniversary of phase out of the desflurane in Canada's largest territory. And so once we made that announcement, same thing. All of a sudden, everybody's really competitive and people are like, well, we're phasing it out next month. So really, the more you can use the social elements that you know from your whole life, bring a new lunch to the lunchroom, all of a sudden people are like, oh, I like the way that smells. Things ripple out like that. And so really part of that is finding your people and purposefully creating community. And another one is viewing your achievements as inspiration. Telling people about that's not bragging. It's showing them a pathway to agency. That gives them a feeling of they too can make a difference and replicate that. So since all we did was just start telling people what they'd already done with regards to desflurane phase out around the country, we've basically got a movement. We met with an MP yesterday. We're putting the Canadian Association of Anesthetists is working with us to put a petition together to phase it out nationally. So don't be lonely. Find your people and really consider how you can make work at both the micro, meso, and the macro levels align in the same direction, because that's when things really start to move.
Thank you, Courtney. I really appreciate your detailed explanation on how to influence climate policy. I think this is going to be a key takeaway for a lot of us. I also saw that you recently published a report, Cradle to Grave, the Health Toll of Fossil Fuels and the Imperative for a Just Transition. What concrete actions can the health sector take to become leaders in the transition away from fossil fuels?
One really concrete thing is for every individual doc in a local place to speak with your community members. So I live downstream from the oil sands, and the Alberta oil sands, the big ones, and the river actually could potentially carry it all the way north, pollute what we sometimes call the northern Amazon, the Mackenzie River Delta, Great Slave Lake. This is one of the world's greatest remaining relatively untouched or very pristine water bodies. And the elders at my hospital were very clear right away when I got there. I live in a majority Indigenous area, that they were worried that basically leakage from these tailings ponds was creating cancers in their communities. That was in 2011, and I went to do a research study. I went to just to go to literature, do a review to see what studies have been published. We hadn't done a decent study. So many of the communities impacted by this are marginalized, racialized, Indigenous. They don't have a lot of connections to the mainstream medical community, and it's tough often to try to advocate in a situation where sometimes your government is very close with industry for proper studies to be done into the local toxic health impacts, because the pollution is local. So really it becomes a local problem, and local advocacy is really important. This many years later, we still haven't done a good study into it. We now have a federal commitment for money. One of the governments involved is trying to basically run a process that does not include Indigenous voices, that basically says, we'll minimally treat those tailings ponds and stick them in the river. And so we finally got a commentary published in the Canadian Medical Association Journal that says we need to do a study. Like it is part of the ethical duty of the medical community in Canada to study impacts on particularly Indigenous and otherwise vulnerable populations. That's part of our job. We're not allowed to look away. And so I think this is one of these things where it's really important we all pay close attention to the commercial determinants of health evidence base. There's some great articles that came out in the Lancet a couple of years ago that they just go through the likely tactics of industry. Sharon Friel is one of the authors on them. And then the tactics that we can do. And so don't go in naive. Read that evidence base. Learn what our scholars have taught us about the lobbying tactics, playing with research. One of the reasons there's not been a study is every time they tried to make a study, they tried to put a fossil fuel rep on the advisory board, and the communities were like, no, obviously we don't want that. But they always try to do that. So know the tactics that are likely to come your way. We need to be very, very good and get better at knowing what the counter tactics are, and just know that standing by our patients in terms of local health impacts is part of our job. And the more we normalize that and bring it into the mainstream of all of our practice, the less scary it will be for anyone, the better we'll be at it and at doing these studies, and the stronger a very local, concrete, tangible push we can put back against these fossil fuel companies that in many cases are relying on our silence and our distraction to just sort of put whatever variables they want in an equation to sell a project based on, jobs or short-term economic benefit, and far too often leave having left a giant cleanup mess that ends up being, a huge negative impact on the community. And frankly, often is the public purse that ends up needing to clean that up afterwards. So we need to be demanding long-term accounting and accountability. And I think that's something that we can do together. And very much the Cradle to Grave report contains case studies from around the world similar to what we're living in the North. And I really think that we'll find courage in community as we work to implement the findings of that report and really stand up for our patients in the face of a fossil fuel industry that has a different bottom line in mind.
That was a brilliant advice regarding the phase out of fossil fuels, the influence of fossil fuel companies, and you also shed light on the impact on vulnerable communities. Thank you for that. I would like to thank you for your insightful answers. We've reached the end of this Q&A session and this session. We encourage you to continue writing in the chat or reach out to our speakers through the People tab at the homepage of for any questions. And thank you again to our speakers and to everyone for your thoughtful questions. We'll move into our networking roundtables, where you can explore the session topics in more depth. Each table runs from now until 1520, and you can choose a discussion via the networking tab at the top of the page. The 4 topics are climate resilient infrastructure, adapting facilities for climate risks, climate resilient technologies, tools and innovation to reduce your carbon footprint, vulnerability and preparedness, assessing risks and boosting readiness, shaping healthcare climate policy, policies that drive change across healthcare. Participation is not obligatory and there are a limited amount of spots. We encourage you to join to exchange ideas and knowledge. If you do not plan to join a table, plenary session 2 will begin at 1520 Central European Summer Time in part 2 of the agenda. We look forward to seeing you there. Welcome back, everyone. I hope you had some insightful discussions during the roundtables. This session, Building Resilience on the Ground, Practical Solutions for Low-Carbon Resilient Healthcare, focuses on tangible real-world approaches to reduce healthcare emissions while strengthening resilience to climate impacts such as extreme weather events, disrupted supply chains, and critical service interruptions. Today, our speakers will share case studies and practical solutions that can be adapted across contexts to support healthcare workers, patients, and communities. I'm delighted to pass the floor over to Gabriela Abruzzo, our Climate Projects Officer, who will be moderating this plenary.
Thank you, Andreas. And again, welcome all to this session. Before we begin, a quick reminder, you can submit your question in the chat at any time. We'll hold a Q&A at the end to address as many questions as possible. Our first speaker for the second plenary session is Egid van Bree. Egid is a researcher and medical doctor at Amsterdam UMC. Today, he will share the work they are doing in Amsterdam to decarbonize anesthetic practices. Welcome to the stage, Egid.
Thank you. Thank you for the invite.
Okay, Egid. Thank you for being with us today. And we can see you and we can hear you well. And we can also see your slide. So I think I can leave the floor to you. And thank you.
Great. Thanks a lot. Then I'll just carry away. Thanks again for introducing me. My name's Egid, and I also just specifically wanted to note that I'm also here today on behalf of Niek and Jasper, who are two fellow anesthetist and resident anesthetist who do a lot of work on decarbonizing anesthesia already for a while. So I definitely don't want to take too much of their credit, hence naming them explicitly. What I wanted to do today is just to carry you around the topic of anesthetics and reducing the environmental impact of anesthetic gases. And this is just a backdrop that I want to start off with, because as a medical doctor, one of the things that, of course, you always tend to think about and care about is also about patient safety in that sense. And I think that's a very important starting ground on this note, is when we're talking about anesthetics or anesthetic gases, there is a perfectly safe alternative, being totally intravenous anesthesia. I added some bullet points to the slide, but mainly to point out that based on systematic reviews, including meta-analyses, my colleague Jasper mainly has previously looked at safety comparisons based on the existing literature of total intravenous anesthesia, that's what TIVA is, as an alternative to anesthetic gases. And similarly, when we're talking about nitrous oxide, which is frequently used as an additional form of anesthesia, so not necessarily to replace one of the other ones, that it's something, if you give it in addition to general anesthesia, that it also, in terms of patient outcomes, doesn't necessarily add value. In that sense, that brings us to the point of, if we talk about more or less equal patient outcomes, or even if, for example, post-operative nausea or vomiting is slightly less frequent using intravenous anesthesia, that could bring you to the question if you can indeed also replace it. Seems rather obvious, but I think it's an important point to start from. And what makes it even more interesting is that economically they're more or less on par, whereas you could spend more time researching that. I think that's an important point. That being said, what are we talking about today? And I think one of the main points that I wanted to share with you, or that I wanted to show you, is the decreased usage and stark decrease in usage of anesthetic gases. And I've listed the three most common ones that are predominantly used in the Netherlands on this slide, grouped per type of hospital in the Netherlands. And then, as you'll see, since for on the left side university hospitals, I have slightly more reference years to draw my slides from, that since 2017 or since 2019, in this country, we've seen a very, very, very strong decrease in use of anesthetic gases, which has predominantly been switched to propofol as an alternative for intravenous anesthesia. And should you wonder why the differentiation between these anesthetic gases, or as you'll see that mostly what remains are yellow bars, that's sevoflurane, which is out of the 3 anesthetic gases listed, has the least potent greenhouse gas. In that sense, desflurane is the strongest greenhouse gas in there, and it's also been the one which is almost entirely phased out in all hospitals. But obviously, you're not here to hear that it's decreased, but one of the questions might be, why has it decreased? So there are 2 chapters that I want to take you through. First one being driving change in local practice. Because if we're looking at this stark decline, then I think there are several points which I've seen at use in the hospital here in Amsterdam UMC, but also across many different anesthetic practices in the Netherlands, which have been driving this decrease. And obviously on the left-hand side of this slide, when we're talking about education or local champions, I can tell you that that is one of the primary let's say interventions or measures that has been going on. And education sounds a bit broad, so to detail a little bit further, what you'll see, for example, here in Amsterdam, being mainly through the work that Niek has done since 2018, but across other centers, many other anaesthetists, they've really been using meetings, either morning reports or additional evening, like continued education meetings, training of anesthetic nurses or anaesthetists to discuss the fact that volatile anesthetics, anesthetic gases, are such potent greenhouse gases, and that you can actually replace them by intravenous anesthesia. And the picture on the left-hand top side, that's actually a slide deck that Niek used when he first addressed it here in Amsterdam, dubbed as the famous Al Gore movie, An Inconvenient Truth About Anesthetic Practice and Anesthetic Gases. There are some other points on this slide which I do think deserve attention. And that is that in some of the practices in the Netherlands, what you'll see is that they use a morning checklist as a way to drive change. At the start of the day, in the operating room where they'll have this going on, they'll have a flashcard which details that for the next 3 months, for example, the focus is to stimulate use of intravenous anesthesia rather than volatile anesthetics, and on the backside, why such a thing would be interesting or would be good to do. And it's partially also about getting consensus among other colleagues in your center, or nationally consensus, and facilitating use. So that relates to you use fewer anesthetic gases if you use a low flow anesthesia. So essentially adding less air when people need to breathe. And that is something which you can facilitate by example, by adding on the machine a shortcut or a very fast button to reduce the ultra low flow, which could be up to, for example, 0.5 liters per minute. So just some of the ways of making it easier, but also definitely increasing awareness or spreading awareness. Now this is mostly based on what I've heard from the anaesthetists that do this across the Netherlands. It's also interesting to look at the scientific literature. And if you look at those, then you'll see that several implementation strategies, or de-implementation strategies, if you will, pass the scene, most of them being related to education or mandatory education, but also being related to, for example, auditing cycles or feedback, to make sure that if you have before and after programs, you can actually also track the change. There is literature on labeling or nudging approaches, so actually putting stickers on, for example, volatile anesthetic containers. I know this perfect picture which says Donald would use desflurane. I couldn't find it, so otherwise I would have used it on my slide. And usually these are stepwise approaches, sometimes pushed from top down, but I think especially in the way care is organized here, usually consensus-based. It's important to note that you've got different target groups to consider, also anesthetic nurses. And one question that possibly remains to be answered is if certain strategies are more effective than others, because mostly this has not necessarily been compared or extensively described. So that is something that you might still wonder about. But obviously you can see how these previous choices for these strategies have resulted in an effect. And that brings me to the second question, because obviously you can do this on a local level, but part of the project that we've been working on is how do you drive change in national practice? And that's what we, with a little wink of the eye, dubbed the Dutch approach to decarbonizing anesthesia. And it's basically a 4-step process. I won't walk you through it in detail. I just wanted to give you the overview, but the article is available online, open access, so you could give it a further read if you would want, which take this approach of research, patient safety, as we already discussed, but also actually conducting interviews with anesthetists in the Netherlands in different places to hear what their arguments are or concerns are to choose for certain ways of anesthesia. Worked on a communication framework, which you partially see on the right, but actually also working on a new addition to a national guideline about sustainability in perioperative care. And essentially that results in the request on a local level to have a local protocol which details or which states something similar to, if possible, we use intravenous anesthesia. If need be, we use volatile anesthetics. And is being integrated in quality control audits by the auditing committee, which audit every anesthetic practice once every 5 years. And the thing we're currently doing, or that I've been working on, which I can't fully share yet, unfortunately, is to do a follow-up implementation study to actually study how this rolls out in practice, using, for example, the example protocol, which you can see on the right. Now, the question that I do want to partially leave you with, or a reflection that I want to leave you with in the time that I have left, is possibly if you're thinking about these different interventions, either on a local level or nationally, it is worth considering what the right time is for which type of intervention. Because arguably, requesting practices to make a local protocol, because it was a nationally, actually accepted guideline change, that of course requires substantial buy-in, also from anesthetists or professionals across the country, which might mean that if you're very early in a transition stage, so you're predominantly using volatile anesthetics in your country, then possibly it would be better to first drive local change or to first use different approach strategies before moving on to a targeted strategy, for example, more towards those who have not decided to change yet, because that would be something that you would need consensus for. It's a bit of a conceptual note to end on, but it's something that I did want to address because I think it requires some attention. That being said, happy to take questions, I think, later. And should you want to reach out or learn more, I address the articles. They're listed on the slides, and otherwise feel free to follow these people on LinkedIn or contact us online.
Thank you, Egid. Your work is really inspirational, and it's wonderful to see what you achieved in these years, and also how you're transferring your work from the local level to the national level. I think it is a really interesting example. Next, we'll hear from Katharina Weiss, Project Manager for the Sustainability Office for at Tirol Clinic in Austria. Katharina will present the climate resilience approach Tirol Clinic has adopted, in particular highlighting the work they are doing in Montadapt project. Welcome, Katharina.
Welcome. Hello.
Hello, Katharina.
Hello. Nice to see you.
Yes,
so
I can hear you well. I'm
Okay.
not sure if I can see you to meet, but maybe the audience can. I think your presentation and your slides are also on the screen, and I think I will leave the floor to you.
Okay, then I will start. If there's any issue, just speak up. So hello everyone, also from my side. It's a very nice opportunity to present today about the different projects that we do to improve climate resilience at the Tirol Kliniken. So I will, maybe first give a little bit of an introduction about our organization. The Tirol Kliniken is a hospital organization that's located in Tirol in Western Austria. And it's the largest healthcare provider also in Western Austria, providing almost all, if not all, medical specialties. So even people from Italy, from South Tyrol are coming here to receive treatment. There's different buildings and facilities that belong to the organization, but I guess our main business is the 3 regional hospitals that we have. So it's Innsbruck, Halle, and Hochzell-Nattes. we have around 8,500 employees. So we are very big, and that's also why we fall under the Sustainability Reporting Directive. That's why also the Sustainability Office was created in August 2023, so we can report on our impacts on the environment and also on the people. But we do more than that. We also have projects, we do networking and try to raise awareness amongst our healthcare professionals. And yeah, climate resilience is also a very important topic for us. Yeah, I divided my presentation today about so I will present to you projects on climate mitigation, but also on adaptation, which are both crucial aspects for climate resilience. Why are they important? We've heard about that a bit in the keynote today, but yeah, maybe just to highlight it again, the healthcare sector is a significant contributor to greenhouse gas emissions, and we also must play our part in reducing our environmental impact. For example, only this week I found out that we printed 2.5 million printouts last month. And also in terms of mobility, for example, we had a very comprehensive mobility survey in 2023, which found that employees of the Tirol Kliniken collectively drive up to 3.1 times around our planet Earth every day. So yeah, we do have a lot of potential to reduce our environmental footprint. But also on the other hand, adaptation is very important because climate change is real. It's already impacting our health. And we have to be prepared to protect population health in the face of increasing climate-related risks. To conclude, we must become climate resilient. And I'm now very happy to have the opportunity to present to you some of the things that we are currently working on. In terms of climate adaptation, I want to highlight our EU project Mount Adapt that started last year in June. And the overarching goal of this project is to have a resilient transformation of healthcare in alpine regions. There's 4 different demonstration sites that are testing and evaluating climate adaptation strategies. In Tirol, we are testing 9 out of those climate adaptation strategies, and there's alongside the Tirol Kliniken also the region of Tirol that are partner in this project and the UMIT University. And I try to cluster the different solutions into 5 overarching themes. So we have nature-based solution simulations for buildings, mosquito monitoring systems and simulations, a training program that is being developed on climate change and health for all healthcare professionals. We have checklists that, for example, focus on disaster preparedness, guidance and recommendations. And then also one online communication tool to enhance workforce planning during emergencies and crises. And today I want to focus on these 3 because I think we already had some interesting findings. For the nature-based solutions for buildings, the objective was to simulate the thermal comfort in buildings using nature-based solutions to illustrate how such approaches affect temperature, humidity, and energy consumption, helping architects and building owners make informed decisions during construction or renovation projects. And for this project, we partnered with CSDB, that's an institution in France, and they are doing a lot of construction consultancy and research as well. So what did we do for this solution? We first started with defining thermal comfort requirements. So for example, we found out that in patient rooms, it's not allowed that the temperature exceeds 26 degrees. Then we selected a building for simulation. So we also wanted to choose a building that in the future is going to be renovated. And then we chose a ward that typically, that has no cooling at the moment, and also that is located on very high floor. So in the summer, they are suffering a lot because of the heat. Then we collected climate data and chose appropriate future climate scenarios, and CSDB thankfully then simulated and analyzed the indoor thermal environment. And here we have the finding one of the findings. So we see in the table the percentage of days during the summer that are considered unacceptable for different scenarios. So the initial scenario is the one that's currently practiced. Then we have, for the nature-based solutions, we chose to look at the optimal ventilation scenario. So opening windows only during night or when it's colder outside than inside. And then we also looked at the potential of greening the facades, and also the combined effect of the two nature-based solutions. And what we see in the table is that in the hottest bedroom, in that ward that we simulated, the percentage of days that are considered uncomfortably hot, because at least 1 hour is exceeding these 26 degrees, decreased from 22% to 17% if you apply both solutions, nature-based solutions, so the optimal ventilation and the green facades. And in the computer room, which was actually even hotter because of all the internal heat that the computers, etc., produce, the solutions of optimal ventilation and green walls have the potential to decrease the percentage of summer days considered too hot from 32 to 27%. Still, there will be issues. So the recommendation from CSDP was also to, in the future when renovating the building, have hybrid solutions and also work with technical solutions to cool down the temperature in the ward in the summer. Another solution or adaptation strategy that we're looking at in the EU project MountAdapt is mosquito monitoring, with the aim to early detect and track invasive mosquito species as climate conditions become more favorable for their survival also in our region. So we placed 3 adult mosquito traps in high traffic green areas across Innsbruck, because those are the areas where mosquitoes also like to live. And I have a picture on the next slide. So what you can see on the right picture is that the adult trap is on the bottom here. I don't know if you see my scroller. And then we have the trap on the top. And if the mosquito flies into the trap, it disrupts the light beam, and then based on how the light beam was disrupted, this sends the information to a server, and we can see what mosquito flew into the trap almost in real time. And that allows rapid public health response. And also we can see like the AI module that's inside the Iridion backtrack sensor, so the one that's put on top of the trap, it enables us to determine the genus, the sex, and age, because it makes a difference if the mosquito is considered dangerous or not. And then, we can see it immediately, and it allows a rapid public health response. And then the last climate adaptation solution I want to introduce that as part of MountAdapt is our training program on climate change and health. We're working on this together with the University of Deusto in Spain. And the objective is to strengthen the competencies of healthcare professionals in addressing climate change through an online training program consisting of 7 modules. What we've done so far is a training needs assessment. So we talked with healthcare professionals and also with scientists. What do they believe is important to learn about climate change and health? And the key findings were that respondents feel most comfortable about their current knowledge of health impacts from heat waves, because there have already been projects before that we're raising awareness of the public and also healthcare professionals on the health impacts of heat. What was also interesting is that participants anticipate an increase in the prevalence of mental health disorders, respiratory diseases, allergies, and cardiovascular conditions due to climate change. And the most important incentives for attending training include paid leave or flexible working hours, hands-on experiences, and certification of acquired competencies. But of course, climate adaptation is not the only thing that we're looking at. Tirol Kliniken mitigation is just as important, and there's a lot of different departments working on that. It's not my main focus, so I will just very quickly introduce them. We have my colleague, for example, working on a Green Lab initiative. That is an initiative where interested laboratories can participate and try to look at how they can make their processes a bit more sustainably. Yeah. She told me that actually there is like checklists that they can go through and see where there's potential. And then one of the labs were able to stop, like, so they have multiple ultra freezers, they're called. So there's ultra cooling devices. They consume a lot of energy, and they were able to cut one, and then that allowed them to save the energy of a 3-person household. So it's quite a lot of energy that they're consuming, and yeah. We have the Department for Buildings and Energy that are always trying to, whenever they do renovation work or build new buildings, try to make it more sustainably. And they always, there's this climate active building standard in Austria that has different criteria. For example, that you use more renewable energy, and they're always looking to, whenever they build something new or renovate, that it's environmentally friendly, or the most environmentally friendly they can build it at the moment. And there's also a lot of initiatives that promote active and sustainable travel. For example, all employees, as I said before, they have a big impact because they're driving 3 times around the world every day. Now we have the opportunity to, or every employee gets a free transportation pass for Tyrol. So that should incentivize them to use more public transport. And that's just a summary. We are of course not perfect, and there's still a lot of work to do, but I think, the Tirol Kliniken, it's on the radar. The climate resilience is important. We've tried to implement the first steps. I mean, nothing is finished yet, but we mobilize the support so far. We're involving a lot of different stakeholders in our projects, and we're trying to make and understand the policy landscape. We also conducted a climate risk assessment, and now it's about identifying priorities, developing strategic plan, how we want to implement climate resilience, and that's it. Thank you very much for listening.
Thank you, Katarina. It really looks like an holistic approach to climate resilience. So you're doing a fantastic job at Tirol Kliniken. And our final speaker for this session is Christa Mois-Bosgra. Christa is the Sustainability Manager at Groningen UMC in the Netherlands. She works to accelerate the sustainable care transition in Groningen by focusing on intervention for system change. She will walk us through the solution they are implementing to boost the facility's climate resilience. Welcome, Christa, and thank you for joining us today. We can see you, but I think we can hear you, I think, now.
Yes, perfect. Thank you.
Yes, and we can also see your slides. So when you're ready, the floor is yours.
Thank you very much, and thank you very much for having me. My name is Christa Mois-Bosgra. I'm a Sustainability Manager at the UMCG. It's a hospital you see in the center of this slide. It's one of the biggest university hospitals in the Netherlands. We accommodate many patients, and about 13,000 people are working here in this facility in the northern part of the Netherlands. Today I will tell you a little bit about the work we do on mitigation. Actually, that's the main focus for us as a sustainability department. But we also show you the first steps we do in adaptation to show you a concrete project we're working on, which is about climate risk. But first, start with the problem. Well, you probably, I think, know this very nice picture, or not so nice picture, you could say, because we have a problem as hospitals. And this lady, which is in the center of the picture, made this picture about 5 years ago. She's a patient at our hospital, and she had a reconstruction operation at her breast because she suffered cancer. But she's also an artist who makes from waste art. And she made this art piece as a picture, but also as a video. And for me, it was really an inspiration to start working on this topic. So yes, we have a problem, and also we as a healthcare sector have a problem. You probably all know this, but this is something we communicate a lot also with all our workers in university hospital, to really connect healthcare to the problem, to emphasize on that the climate crisis is a healthcare crisis, the most important healthcare crisis of this century, and what are the consequences of that, to make sure also the healthcare workers feel responsible for this. As a department, we know that transition is not easy. Actually, it's not a linear process, and it should be answered also with a strategy of transitioning. And this is what we aim to do. And we have different perspectives on which help us to do that. One of them is the transition thinking method of Nyenrode University in the Netherlands. And this is a model of the maturity of a transition, which says that sometimes you have to take initiative. This is in the inception phase. After that, you have to really work together on the certain initiatives to scale them up. The next phase is really to collaborate with a lot of hospitals. We do that a lot in the Netherlands, also with Amsterdam, which you saw before. So the other university hospitals, but also in the region with businesses, companies, etc. And then there's a new normal. And actually, we have to realize in transitioning to sustainable healthcare that we have to do with a lot of transitions. So not only the healthcare transition has to become more sustainable, but in transitioning a hospital, we also have to do with the energy transition, with the circular transition, with the food transition. So from that perspective, we also always plot on which is the right intervention to do at what time. If you talk about the hospital itself, there are also two different dimensions which are very important for us. And one is the bottom-up sustainability. How do you say it? Dynamic. So we have in the university hospital, we have 51 green teams. And green teams with us is a group of people from a certain department which say, well, we feel the urge to make our department more sustainable, and we will spend our time and energy in doing that. And this helps us a lot to make our hospital really sustainable. And we as a sustainability department really support these green teams in helping them in becoming making the whole hospital more sustainable, but especially their department. And one example is that, for example, we hand out this trophy. The board of directors did that the first time to a team which really deserves it because they have great initiatives, and actually the next time this team will give the trophy to the other team. This is one thing on which we support the green teams. But from top down, we also have a sustainability program with our ambition to become circular and climate neutral in 2035. This is faster than the Green Deal Sustainable Care in the Netherlands. But this Green Deal does really support us in making it happen. And also, if you look at the teams below, the 6 teams, this is strongly connected to this whole Green Deal. If you don't know about it, it's interesting to learn because this Green Deal is we signed this with all the parties actually of healthcare in the Netherlands. So the insurance companies, the banks, all the healthcare providers, etc., to work on clear goals together and how to do that. And this really helps us in the transition. It's also connected to the sustainability goals, as you can see on top. And we focus on healthy environments, knowledge and awareness, sustainable energy and construction, sustainable travel, circular operations, and sustainable use of water and medicine. And I'll show you just some examples of 2 of them to get a bit of picture of what we do. So one is, for example, circular business operations. There we work a lot on reduce projects, for example, no risk, no gloves. So only use gloves when it's needed. And actually this program already saved us 500,000 gloves for the first half year. So it's quite effective. And actually, I forgot to mention, but the whole program entails about 100 projects. We have funding from the university hospital on that, but we also have a lot of funding from national, regional funds and subsidies in order to support everything that we do. So that's what I wanted to let you know, also to see, whether you can get also external funding on your project. It really helps us also to get funding from the hospital itself. And Care to Change is also an example of this regional initiative for which we got 6 million funding to make sure we get hospitals without waste. It's a cooperation between the hospitals in the northern of the Netherlands, businesses, and also knowledge institutions. For example, another funded project from the government was the National Inventory of Medical Disposables, which really helps us also to focus on, okay, which disposable is mostly used, has the most environmental impact, and we should start on working on in order to transition to a sustainable hospital. And on energy and construction, we have a heat and cold warm sourcing system with thermal heating. We installed 2 of them now in our hospital. We have solar parks, and we are planning to build also a new lab building, completely made out of wood. So I think we go well there also. Until 2023, we saved about 17,000 million CO2 in doing that. So we still have a lot to go, but I hope we'll get there anytime soon. So the first steps on adaptation, I would like to show you one concrete project which we're doing. It's a project on climate risks. So we map what is really the risk of our hospital in terms of building and operation if you look at the climate impacts we have right now, and looking into the foreseeing future of 2100. As you can see in the video, I'll try to start this. Maybe it has some noise. Actually, in the back, what you see is a part of our hospital. So you can imagine, I think, what could be the impact of such an event on the operation. And I will not go completely through this slides. I have 1 slide on process and 1 on methodology. It just gives you a peek on the process we're into to map these climate risks and the methodology that we're using. And if you want to, I think these slides will be also available for you after this event. But if you go to the methodology, what we do is to identify what is the climate risk, what is actually the impact on our operation and on our people, what is the chance it occurs in the end, what is the end risk, what are the other considerations we have to take, and then what is the prioritization on what we have to do. So we are now currently in this process. And it makes already clear what risks UMCG is facing regarding climate change and which action we should take upon it. And if we look at the different categories for us as a hospital, you see that more rain, rising sea levels is 1 we have to take into account. 2 is more warmth and dry weather, and 3 is extreme weather conditions. And if we focus on the first category, you can here see how we map what kind of expectations we could have towards 2100. What is the rating that it occurs and what is the current situation? And then you can see, what is actually the biggest risk if you look at rain and rising sea levels, which we will be facing towards 2100. And for us, the peak rainfalls is then, for example, much more risky than the flooding of barriers. Later on, I come back to that also. Here you see just a map of Groningen. The gray area is the building area in the middle of the hospital. And here you see what happens with rain showers of 70 millimeters or of 140 millimeters. And then if you look at the right picture, you could see that a lot already is blue, is flooded. And that really would impact our operation in for example, cellars being flooded, people that are patients, workers that are not able to enter the hospital anymore, things like that. So in sum of that, we did this exercise of analyzing the climate risk. We are still busy in finishing it up. Our learnings from that is it's quite a complicated scientific situation, but there's a lot of public available information that you can use in order to estimate the climate risks. For example, the weather forecast companies, the local governments, the governments in Netherlands, which is concerned about water. But still, there's some time that you need to analyze this, and we really did that together with the local government, who also learns from that and can help you with that. The method is something that can be copied, but the situation is actually quite locally based. So you wouldn't tell, but in the northern part of the Netherlands, we're, as you know, a lot below sea level. But in Groningen, we are on a certain hill, which is created actually by the last ice age. Interesting fact to know. So flooding for us is less relevant than it might be for other hospitals, but extreme rainfall then is more relevant. So the risks can be different than we would estimate maybe before. And a recommendation that we can also give is to use the ISO norm mentioned here, because they also have quite a nice process in place to assess risk. And the next steps for us, and this is something we're working on right now already, is to look whether we can capture rainwater. This is also on new buildings required from the government to do, but to see how we can capture rainwater, how we can have a separate rainwater sewer so we can move rainwater with heavy rains easily. And in terms of capturing rainwater, we also have a look at whether we can cool our buildings with that, use it for our green environment, maybe to flood the toilets, etc., etc. So these are things we are working on right now. And actually, that was the end of my short presentation. I hope I inspired you a little bit by what we do in a university hospital and how we work on mitigation and adaptation. And of course, if you have any further questions, you can always email me.
Thank you, Krista, for presenting the work that you're doing, especially the climate risk analysis, because still it's not a common practice at healthcare facilities. So it's really interesting to see your work. I would like to welcome back on stage our speakers for the second session. We don't have a lot of time for the Q&A, so I will ask the speakers to provide a quite concise answer. I would like only to ask you if you can provide a really short takeaways, lesson that you learned in your work in sustainability that they can take away with them after this session. I don't know if Eki, do you like to start?
Yeah, great. But I would say that some of the key lessons which I experienced is how important it is to have a local champion and or someone who's essentially who's responsible also from possibly a clinical perspective to keep on driving change, because some projects, even though they're small, they can involve a lot of people. So you need at least one person, preferably more, who are willing to do this together. And I would say that the second thing that I'd really like to mention, or that I prefer to mention, is that many sustainability projects, talking from workplace alterations or introducing certain changes, I believe they're very much like getting a group to get on a train if you want to move somewhere. Essentially, as long as the train is waiting, people tend to debate and tend to take time. But as soon as the train starts moving, then all of a sudden loads of people want to join. So sometimes it's more important to get started, even slowly, and then you'll see that more people come along rather than waiting for everyone to board the train before you leave.
Yeah, thank you, Agit. Yeah, so I agree. Sometimes it's way easier just to start and see what happens than just waiting. Katarina, would you like to go next?
Yeah. So I would say my key takeaway from working in sustainability is that in a big hospital, is that networking is very important. I think speaking with the people on the ground is really essential. Understanding their problems and concerns, and getting to know their work as well. So so not only coming and asking, oh, can you help me with this project, but also maybe understanding what they're doing on a day-to-day basis, and then talking together how you can work on projects together. And the second thing is also to start small. I think big projects are usually very difficult to implement. There's so many stakeholders involved. Even if you have a small project, as Egit said before, there can already be so many people involved. Especially in healthcare, you have so many different professions working together. But if you have like smaller initiatives, it's just easier, and you can work on different aspects at the same time. So, for example, you work on buildings and infrastructure while also working on mosquito monitoring, and that's, I think, one way as well to become more climate resilient and hopefully take a lot of people with you on this journey that are required.
On the
question, sustainability office cannot do anything for others.
Yeah, I think it's essential to connect with the others, especially at a healthcare facility, balancing the sustainability, also the clinical aspect. And Krista, the last word from you.
Yeah, I think in some also about what is already being said, I think we as a department, we really we see ourselves as the one who try to fasten the sustainability transition and try to help the hospital themselves, so the people themselves and all the departments themselves to become sustainable. So not as a separate group, let's say you're going to solve it, but us to enable them to solve it themselves in terms of changing the culture, in terms of funding people. And as Egit is saying, once you reach the tipping point, of like the 25% who are actually executing your project, working more sustainable, working on sustainable materials, then things go really fast. So sometimes you maybe feel like, okay, why is this not moving? But just wait and look clearly if it's the right time to move, and if so, just start, as Egit saying as well. And soon you'll be in this train, like with the anesthetic gases, and things go really fast.
Yeah, so I think this is the moment to end the second plenary session. So I would like to thank the three of you for sharing with us your work. I think our audience is being get inspired by everything you're doing. And let's get started with today's closing session, the road to a resilient health sector. So far, we had a packed day of discussion on building healthcare climate resilience through mitigation and adaptation and the critical role health professionals play in driving climate action. To wrap up, we are excited to have three exceptional experts with us who are working at the forefront of clinical and health, sharing insight with us. I'm very pleased to introduce Diana Picon-Magnari, International Climate Senior Director at Healthcare Without Harm. Diana has over 20 years of experience working with international organizations in development and public health programming. At Healthcare Without Harm, she oversees the global climate program and the implementation of the organization climate strategy. Welcome, Diana. It's really great to see you.
To see you too, Gabby.
And thank you for joining us today, obviously. And our next speaker is Francesca De Donato. Francesca is a senior environmental epidemiologist at the Department of Epidemiology of the Lazio Regional Health Service. She manages the Italian National Heat Health Warming System on behalf of the Ministry of Health and the Civil Protection, and contributes to the Italian and Lazio regional heat plans. Welcome, Francesca. And thank also to you for being with us today.
Thank you very much. Good afternoon, everyone.
And our last speaker for this session is Patricia Naina Schwertel, a global health academic with extensive clinical expertise across the Asia-Pacific region, Sub-Saharan Africa, and Europe. She's affiliated with several organizations, including the Heidelberg University. She specializes in the nexus between climate change, migration and health, and climate resilience, and low-carbon health system in low and medium-income countries. Welcome, Patricia.
Thank you.
Hello, Patricia. And thank you also for joining us in this discussion. I would like to kick off the discussion of this closing session by focusing on the overarching theme of this year's summit, climate resilience, seen as the combination between mitigation and adaptation. And I would like to start with a common question for all of you. That is, how can we effectively overcome this separation and foster an integrated approach to climate resilience? Could you provide, based on your experience, some initiatives or strategies? I would like to start with Diana for this question.
Sure. Thank you so much, Gabby, and thank you for the invitation to participate in this year's summit. Your question is really interesting because we are, I think, at a really interesting point in which we start talking about these two things. First of all, the fact that we're talking about these two things in this very summit, as part of a wider, broader resilience framework, if you will, it's already a huge win. We have been seeing these two areas of work, adaptation and mitigation, as so separate, sometimes even against each other, when we could be looking at this in a way in which we talk about how adaptation and mitigation actions can actually reinforce each other and should reinforce each other. And sometimes I think that that's just an error of perhaps our not wanting to create a complexity, to look at things separately because it's easier. Or sometimes it's a lack of imagination, to be very honest, from leaders. At Healthcare Without Harm, I think that we've been doing a few things about it. First of all, our new international strategy is all about building climate resilient health systems that tackle both. And so doing that already as an organization, we're saying this is important to us internationally. Last year, we made a commitment at the Clinton Global Initiative. It was a commitment to action, not only to increase the number of Race to Zero participants we have in our global network of hospitals, but also ensuring that the reporting improves and that we start introducing adaptation guidance and tools for our members. You in Europe have already been doing it with Mount Adapt, with Live Resistal. Our colleagues in Southeast Asia have been doing it in several countries now. They're actually, I think, this week going and helping some members doing vulnerability and adaptation assessments. It is really exciting to see. And even in India, our partners are also looking at doing this at a health facility and at some national levels. With the support of our Latin America team, we have been identifying examples of health systems and health facilities who are combining the strategies of adaptation and mitigation. And we've actually used that and shared that with the COP30 presidency in their green area solutions that they're going to be presenting as part of the action agenda in Belém, Brazil. And finally, just recently, we developed a series of recommendations for the Asian Development Bank that ensures those connections between low carbon and adaptation actions are taken into consideration, particularly when they're looking at where do they invest, how do they provide loans for adaptation and mitigation at a national level, as well as how do they write grants also for certain countries. So these are the things that we do. They start at the smaller level, they start with different stakeholders, kind of starting to take a different approach at how they look at what is a good action in the climate space in healthcare. Thank you.
Yeah, thank you for your answer, Diana. Obviously, me as part of Healthcare Without Harm, I think I'm proud of the work all the offices are doing, and it's really nice to see how everything is moving, not in a separate way among the regions, but is driven globally. So I think that's also really important. Francesca, now I would like to ask you the same questions. So how do we overcome this separation?
So thanks, Gabriela, for the invitation as well. It's really nice to be here and follow the event and listen to how things have been progressing in the last year. Going back to the question, I think one of the crucial aspects coming more from the EPI world and the public health world, in which we have to show the evidence and provide data, is to raise awareness and really show what the co-benefits are and the fact that they are linked. So having some strong indicators, developing indicators to show the benefits for the healthcare system in terms of addressing this issue. And on the other hand, in terms of policy and governance, really creating a strong nexus between environment, climate and health, which is one of the issues, because often there's a lot of will or interest in doing it from a public health perspective, but maybe we don't have access to the environmental data that we need, or the climate data that we need, or the resources. So I think from a public health perspective, or even from EU projects, I think strengthening the link between climate, environment and health is important. In Italy and internationally as well, there's been a lot of work doing. We have regional and national task forces now, which engage institutions, experts, stakeholders and policymakers from climate, environment and health, which really puts the framework and the resources that are available to address these different aspects, both in terms of resilience and sustainability. And then that favors the policy as well, because you can address these aspects. In Italy, we are adjusting and addressing it in our national prevention plan and the new scheme for the next 5 years, for example. And this can only be done if there is a task force which would give you the data and provide the evidence. And again, going back to evidence and what the research can say and can be translated to these two worlds and show the engagement and the link between sustainability and resilience within a healthcare system, I think results from projects that are ongoing in the climate cluster, for example, of Horizon. I work in the Catalyze project, and we're focusing explicitly on healthcare system adaptation and mitigation. And again, they're not treated separately, they're in the same thing, and we're providing frameworks, and we're really addressing it again at the different levels. So it can't only be, there's been a lot of work being done at the WHO level or European level, but that needs to trickle down into the reality of how health systems are organized. So it needs to be at the regional level for the policy, and then very locally for commitment and action. So I think it's that link again in task force or collaborations that needs to be carried through at the different levels, and providing the data and the information they need to show the benefits, again, of the different actions, to give a push to the policy and drive them in that direction.
Yeah. Thank you, Francesca. I really like two elements of your answer. One that is highlighting how actually climate resilience is a really complex puzzle that obviously we talk here about climate mitigation and adaptation, but we have to also to consider the health aspect that is essential as well to assure the climate resilience of a system, and also the creation of task force, because it's essential to tackle to increase climate resilience, to work with different stakeholders that are maybe traditional not involved in the healthcare sector. That was really interesting. Trish, I would like to hear your opinion on this topic, on how to overcome the separation.
Yeah, thanks, and thanks again for the invitation to speak. It's been a really fascinating summit so far. I do think that we really need to stop framing mitigation and adaptation as separate and also as sequential. It's kind of two different problems. And even though we're kind of sick of hearing this at every climate change and health conference or summit that you go to, people will say we have to stop working in silos and they're two sides of the same coin, and we're almost sick of hearing these cliches. But then we fall into the same cognitive trap of saying, well, I mainly focus on adaptation, or this project is mainly about mitigation. So I think we actually have to kind of practice that rather than just kind of repeating these cliches, and have to start thinking about synergistic, or not just start thinking about synergistic interventions, because it's not like adaptation is new. It was from the inception of the IPCC, they were talking about adaptation, and everyone talks about the 1.5 mitigation goal, but at the same time, the global goal of adaptation was set at the Paris, for the Paris Agreement, and that's 10 years ago now. So we actually don't have time to think about this sequentially either. So I think, like, if you can think about the work that you're doing and ask yourself, not next, but at the same time, how is this mitigation activity adapting to climate change and building resilience? And how is this adaptation activity low carbon? I also think we might need to stop thinking about just decarbonisation in high-income countries, because I think it only gets us so far. My main work is in low and middle-income countries and resource-constrained environments where health is much less resource-intensive, less expensive, more community-based, less downstream and medicalised. So, we've kind of almost maladapted, or we have maladapted in high-income countries. We call ourselves as if we have strong health systems. But one definition of maladaptation is that you lock yourself into a carbon-intensive pathway, and that's what we've done. So if we kind of just limit our thinking to footprints and mitigation, then we're only going to get ourselves so far, because we're kind of locked into this maladaptive pathway. And in that way, I think we can learn a lot from resource-constrained settings, where they're low carbon out of necessity, not out of design.
Yeah, thank you for your insight. I think it actually linked really well with the next question that I have for you, because you have a lot of experience in working with different organizations, such as health facility system and national authorities. And actually, Trish, I wanted to ask you, because you wrote a paper about building climate resilience in a system with focusing was taking place in Chad. And I would like to ask you, can you share the main challenges that you had there and the lesson learned? Because I think it's also really important for us. For Europe, we always think that Europe is, as you said, is teaching the other, but sometimes we have to learn from the other. So what can you share from this experience?
Yeah, we did a facility-based vulnerability, capacity and adaptation assessment in a rural hospital in Chad with 80 beds, and they mainly deal with pediatric malnutrition and malaria. So we took the VCA to the facility levels to do kind of bottom-up adaptation. And, although it's almost taboo to talk about mitigation in Chad, which is one of the lowest emitting and most highly vulnerable countries in the world, one of the lessons learned was that the staff there and the people that run that facility are actually really interested in reducing their environmental impact. So, of course, they're not talking about emissions, but they're talking about independence, like energy independence and energy freedom from the grid. And they're interested in streamlining the use of their resources to reduce waste. So that was one of the biggest lessons learned. And I suppose we did actually get a bit of criticism when we published this paper, where some of the reviewers said, how dare you talk about decarbonisation in Chad? And I think it's kind of a language thing as well. We need to talk about decoupling health system strengthening and universal healthcare from emissions in those settings rather than decarbonising, because there's nothing to decarbonise. But if we can demonstrate and measure this decoupling in some settings and in a place as extreme as Chad, then that could be replicated in other settings. And I suppose the main challenge was, one of the challenges was just human and institutional capacity. So when you're working in settings like that, you don't have the luxury of a sustainability officer. You don't even have enough doctors and nurses for all the patients. You're working like the health workers there are working in 50-degree environments, and they're looking after like 50 patients. And when it gets too hot inside, they go outside to an old tent where it's still 50 degrees, but you've got the dust as well. So these are the situation that people are working in there. But still, there is still interest in building climate resilience in those settings. So the team were really interested in what are our vulnerabilities. We deal with droughts and floods and peaks of malaria and meningitis and malnutrition all the time. So I think the other lesson learned is really that it's not just about niche interventions that build climate resilience, because climate resilient health facilities are also resilient to pandemics, to conflict, to increases in migration flows. So they're resilient generally, not just to climate change.
Yeah, that's really interesting to hear. And also the part on reframing that seems not perfectly fitting to talk about decarbonization in Chad, but if we looking for a point of view of energy independency and or the waste, I think it makes even more sense. Next, I would like to ask to Diana, because Diana, you collaborated previous Healthcare Without Harm and with Healthcare Without Harm with different national authorities and organizations to support climate resilience, the increase of climate resilience. Can you find similarities in terms of challenges among those actors? Sorry, Diana, I cannot hear you.
Okay, here we go. Finally. Sorry about that. Was having problems with the unmute button. No, thank you for that question, Gabby. So I have been working in the resilience space for about 12 years. And when I started, it was in some early stages of understanding how to measure resilience. And this was not in the healthcare sector. It was around food security. And working with communities that were affected largely around droughts, pastoralist communities in East Africa. There were a lot of experiments being tested about how do we reach resilience. And one thing that we learned over the years was that our efforts helped a lot, but they were limited in time. Because in many of these places, you had protracted crises. Right now, you had like something that was a drought that could be extended in time, and then it was combined with other crises like conflict. And those systemic actions you want to take as an outside actor, so not as a national government, lost their effectiveness over time. And one of the things we found was that social cohesion, the power of your networks, the power of your trusted relationships in a community was just as important as perhaps all of these interventions that you are trying to put in place. But that social cohesion also erodes, and it can be due also to climate change itself, because people move, resources become scarce. It can also be due to misguided policies, like Trish was talking about maladaptations. And social cohesion is hard to monetize or evaluate in terms of traditional ways of return on investment. Now, why am I talking about social cohesion here? I mean, when we're talking about communities, we could be talking about this community here of medical professionals, environmental professionals, people who really care about where they work and how they're doing the work in health facilities. And we can also be talking about those particular communities that we are trying to support. And when we talk about solutions that increase our ability to adapt to a changing climate, we immediately think of the solutions that you can show saving, or you show an economic savings or a gain in health outcomes too. And certainly they might be the right solutions depending on the outcome that you're looking for. But we often fail to think about the more systemic solutions that make sure that we protect our communities. In that Asian Development Bank paper that I talked about recently, we put certain solutions that were very much focused on the facility, some that were focused around health systems governance, but then there's also all these other things that we don't have in the majority of the world, and that in many countries in Europe do have, and that I hope that you continue to protect. Universal healthcare, social services, safety nets. Those can be very effective in building resilience of those communities. And they also help build a sense of collective responsibility, of community strength, and can protect us and build our coping capacities to weather these climate change impacts. And of course, as we've said, we cannot forget the mitigation actions that are needed at the same time.
Thank you, Diana. It was great to hear your answer. Francesca, now you work a bit more, I would say, internally, because you work for the Lazio Regional Health Service in Italy. So what are the main challenges for a regional health system, and especially in relation to collaboration and coordination among different actors that need to drive climate resilience, but also the need to collaborate in case of climate emergency?
Yeah, thanks for the question. So yeah, within our context, I would say, I mean, the main challenges are widespread, not only for a regional context, but I think they would be the lack of clear governance and policy, which allows us then to, intervene and dedicate specific resources, both, financial resources, the economic resources, and human resources for specific actions related to resilience, obviously. But there's also a lack of awareness and knowledge on what climate resilience means, or what mitigation means in terms of the healthcare system, and what data you might need and how you would do it. So I think framing the issue and not really, to some extent, scaring them away to that extent, because they think it's something completely different, because it starts with climate and action, while a lot of the actions really already happen within a healthcare system, right? We have emergency response protocols, we have preparedness protocols, we carry out VNAs constantly for a whole series of different things. It's just changing the mindset and the framework and giving them an overview of what is already in place and can actually work for climate change response as well. I think there's much more is being done, at least in Italy or in my context, on emergency. We're very good at dealing with emergencies. So if it's extreme temperatures or flooding events or other emergencies that happen in the healthcare system, which happen all the time, to be honest, it's more the long-term and medium-term planning that I think really needs a lot more attention when we're talking about climate resilience in the wider context as we are now, because obviously it needs longer-term planning, resources, and actually training healthcare professionals to recognize, for example, the different climate-related illnesses that are emerging, which aren't as common. We had a whole series of different infectious disease in the Lazio region this summer that are not common at all. We had Zika a couple of years ago. We have different things occurring that are still occurring today, which we're not, as accustomed to as we are for other things. I mean, heat-related risks are the norm every summer, I would say. Other effects are, they're multiplying and adding, and I think we need to make sure that we can respond to this not only as an emergency protocol, but it can't be treated as an emergency throughout the year. It needs to become a more systemic and systematic approach as well, and you need to change how that is managed and dealt with. So I think that's one of the biggest challenges, together with resources, which is quite common, we always say, but that's the reality, unfortunately, within our healthcare system at different levels and throughout the different authorities. It can be within a hospital, within our services and healthcare, and the different facilities, its personnel and whatnot. So, and I think even more awareness and training or engagement, as I said before, and these task forces are useful, because where we can delegate or get information from others is essential, so we don't reduce our resources as well. So I would say these are the challenges, but again, also the opportunities for wider collaborations that then we can also use and maximize the resources in public health and not add an extra burden, which is the finite or last goal, right? And we have to use our resources in the best way to ensure that the population is, healthier and it's not suffering from climate change together with everything else. So I think it's an opportunity as well, but it's hard to really get there.
Thank you, Francesca. But I think already being aware of the challenges, I think is the first step kind of to face them and solve them. I would like to ask you, the two of you, more questions, but unluckily our time came to an end. So I need to thank you, and it really was interesting to hear your answers, and really thank you for sharing your experience, because you have really great experience in climate resilience and in the nexus between health and climate, and in collaboration with different stakeholders, with different organizations. So it was really an incredible opportunity for me and for the audience to hear your opinion, your overview on this. So on a final note of this year's summit, I would like to briefly mention that tomorrow, 10 October, is World Mental Health Day. And this year's theme is access to service mental health in catastrophes and emergencies, focusing on the urgent need to strengthen mental health support in times of crisis, such as natural disaster, conflicts, and other emergencies. These crises cause emotional distress, with 1 in 5 individuals experiencing a mental health condition. So supporting mental health and well-being of individuals is essential to save lives and give people the strength to cope and recover from climate-related shocks. And as well, it's really important to support the healthcare professionals that are at the forefront of this crisis, that have to provide the healthcare service also in case of extreme weather events. So thank you. I would like once again thank our panelists for their contribution. I also want to thank all the speakers who shared their knowledge and experience, and the audience, so you, for joining us today at the 7th edition of the European Healthcare Climate Summit. I hope that you leave the event with new ideas and motivation on how to create a more climate resilient healthcare sector through mitigation and adaptation, the two essential pillars of resilience. And if you have found this event interesting, I would like to invite you to Climate Barcelona, happening on 29 October. This unique in-person event will cover key topics in healthcare delivery. You can learn more about it with the link on the screen. As the event ends, a short survey will appear on the screen. Please take a moment to share your feedback. It really helps us to improve future events. Thank you again for joining us today for our 7th annual Climate Summit. We hope to see you at our upcoming events. Thank you.